There we are. We are live. Let me just check on my phone because I always have to make sure we're here so I know we're live when I see us both chatting away. Okay, this might be the old one. I don't know if that's actually live. I'm not seeing us go live yet, but send us a little bubble if you see us on here so that we know we're live. Anyways, welcome to VBF Facebook Live, the Black Friday special. I'm having a little problem here with my phone, so let me just make sure we're okay.
There you are.
Okay, that's it. Oh, where'd it go?
We're live.
We were there, I know, but I just lost it. That's not live.
No.
I know. So it was just there. Let me just find it. There we are.
Yes.
All right. Thank you. Already got a comment. I'm sorry we didn't see you all. Hi, Kaylee. Hi, Gina. Hi, everybody. Welcome to the VBF 2024 Facebook Live, day after Thanksgiving, Black Friday, annual Sturge-Weber Syndrome special with Dr. Ann Comi of the Kennedy Krieger Institute, Hunter Nelson, Kennedy Krieger Institute, you're the director, and our pioneer actually leading research all over the world for our beautiful and precious Sturge-Weber babies. You've got a lot of hellos. Alexandra Boutois Mirescu is saying, hi, Dr. Comi.
Hello.
And
I'm glad to be here.
Yep. And Elton Martinez is also on saying, and Kaylee. So hi, everybody. So today we're going to be talking about all things Sturge-Weber, any new developments. We're going to let you know what's going on next month, what's going on next year. So we will be taking calls as soon as you submit them. So as soon as you start submitting your questions for questions for Dr. Comi, we'll be answering them. I see, hi Kiana. Kiana's on from Trinidad. Alice is on. Let us also know where you're from, and we hope you all had a safe and happy Thanksgiving. Those of you that celebrate here, some of you celebrate Thanksgiving in other places. So we hope that you all had a great time. Hello, Alexander. So let's talk about before we get our questions, what's new in Sturge-Weber research?
Well, this past year there have been a couple of really important research developments. The first was our paper that we published in January, looking really closely at 92 babies with Sturge-Weber syndrome, and the data basically shows us that making the diagnosis of brain involvement early in the first few months of life and treating before the seizures start for the babies who do have significant brain involvement can delay or prevent the early seizures before 2 years of age and result in better outcome. And so that's a really exciting and important discovery that we've made, and it is beginning to change, and should be changing how quickly we need to get these babies in after they're born to see not just the vascular dermatologist to treat their birthmark, but to be seen by ophthalmologists and neurologists, child neurologists, to really screen for and monitor the eyes closely, but also aggressively try to diagnose these babies before they have seizures, before they have symptoms and their strokes and developmental delays. So that's one really big piece, and I'll be working closely with Linda and VBF on the effort to continue to get that word out, because a publication and a discovery doesn't mean anything if the parents don't learn and the clinicians don't learn how we need to be changing care. The other really important discovery this year, we published a new genetic developmental mouse brain model. So it has the R183Q, GenEQ mutation and abnormalities, and we published our first paper. We continue to work with that mouse model to develop other aspects of the model for looking at how the mutation causes blood vessel abnormalities in the brain, the skin, and the eye, and what we can do about that. So trying to move in the direction of newer, better, more targeted treatments. And those are, two really big areas. We are also working in the direction of a new drug trial. Not yet ready to announce it. It's very close. We hope to be getting that started and announcing that in the next couple of months. And and so those are some really big areas. We are working with a couple of different groups. We're starting new work with a group at Hopkins and the Kennedy Krieger Institute on new neuroimaging ways to look at the brain and understand what's happening. A lot going on, and really, even more so the message that the VBF has had for some time of early diagnosis. Early.
And I want to emphasize something, because you're actually doing a paradigm shift today for the families. In the past, you would say, well, even if you had an MRI before age 1, you still need it at age 1.
Right.
We've got to rule that out. And we just saturated the world telling them that.
Yeah.
Now you're saying the earlier to birth,
right,
you can get this MRI done.
So, I'm now trying to get kids in before 2 months of age. I'll see them at 5 days or a week or 2 weeks or a month, but in that first 2 months of age, you can get a non-sedated MRI in a baby, so you don't have to sedate them. They just feed them, wrap them, and put them in the scanner, and they sleep right through it. And so we're not always able to make the diagnosis early, but we have to try. And we are also learning the really subtle changes that happen very early on the imaging, so that we can know who to be suspicious and follow really, really closely, and who looks like they're going to, probably be fine, and we just follow them in the standard way that as we have been. We're still getting imaging after a year of age, but we're being much more aggressive about, getting a referred baby in within a week or two, and really trying hard to figure out if they have brain involvement so we can treat.
And what I really want them to understand that you're saying is, so if you image a baby that's, say, 2 weeks old,
Mm-hmm.
and you definitely see brain involvement, but there's been no seizure,
Correct.
you're going to treat that baby before they start the seizures.
Most likely,
and that's
yes.
going to give us the best hope for...
That's right. Because with the seizures, when they happen early, babies seize for a long time. They can seize for off and on for days, and they frequently come out of those initial seizures with a new stroke, basically weakness on one side, can't see off to one side, and if that keeps happening, then those problems don't go away.
You can't reverse them.
Right.
So that's why we're trying early intervention with the vision. Even if the glaucoma is not picked up, we're looking for subtle nuances with how they react in sunlight. The eye watering more, tearing more, appears to be a little different, to really get a good exam under, not just in an office, because that's where you really got to see if it's really behind the eye, like involved.
Yeah, I mean, I think the biggest piece there is to not let someone who doesn't really know tell you that, did a good exam, pressures are good, you're good, you don't have to come back. That is not true. So depending on the extent of the birthmark around the eye, it may be okay to come back every 6 months, or that child might need to be back depending on what they're seeing, in a month or 3 months, but they definitely have to be monitored those first few years of life, because that's a peak period for developing glaucoma, which can be missed and cause eye enlargement and vision loss. And we want to prevent that by diagnosing the eye involvement with abnormal blood vessels, with early evidence of pressure changes, even if it hasn't injured the eye yet.
Right.
So, technically, some eye doctors will call glaucoma. It's technically elevated pressure with eye injury of the optic nerve, and they won't. Some just don't treat before they start to see changes, and that's just not the way to go. Like the drop needs to be
new way.
Yeah.
The new
Yeah,
way is let's
right.
prevent this.
Right, exactly.
So we've got a lot of questions coming in. So Alice is saying, hello, we are from Romania, Bucharest. Hey, we were just talking about that as a possibility of coming there, which we will. We have a boy 8 years old with Sturge-Weber syndrome, and he's had a glaucoma operation. There's no question. So I don't know, Alice, what your question is. But she says he's 8, he has Sturge-Weber, and he's already had surgery for glaucoma. I don't know if we know a prognosis if that's...
It's so variable. If the glaucoma surgery was successful and the pressures came down, you just need to continue to be monitored, because that can, again, over time change. And so... the children who've had surgery definitely need to be monitored closely, because
How frequently?
depends on the kind of surgery they
Right.
have and when and what the response was. I mean, and if you are concerned that your pediatric ophthalmologist doesn't know enough, then try to get out and get to a vascular center where you can see someone who knows about Sturge-Weber syndrome. So, I mean, I know a lot about ophthalmology because I direct the center, but certainly when patients come with those issues, I direct them to our glaucoma specialist.
And we have some as well that they, depending on where
Absolutely.
they live. So.
Absolutely.
We have another question from Romania. Hello, Romania. I hope you just saw our post that will be coming in November of next year. We have a boy with 5 years old with Sturge-Weber glaucoma and a choroidal hemangioma of the right eye. Is that considered still an ophthalmic?
It is. So that's not uncommon. It's abnormal blood vessels at the back of the eye, and the ophthalmologists use the term hemangioma, but it's not the same thing as far as we know. There have been very limited studies that actually look at the mutation, because obviously getting tissue from the back of the eye, that's challenging. But from what we've seen, it's the same mutation, not the mutation that's not the hemangioma that we see on the skin, abnormal blood vessels in the back of the eye. And the issue with that is that sometimes they can bleed. And cause vision loss because of retinal detachment. But the important thing, again, is to be in with a good glaucoma specialist, and then if the retinal choroidal hemangioma is causing an issue and it's involving the retina, then sometimes they'll refer to retinal specialists. The retina is the back of the eye where light comes in, and specialized cells send those signals to the brain to process vision. So if that's a concern and there's problems with the choroidal hemangioma, then it can be important to not just see an ophthalmologist, but a glaucoma specialist and even maybe a retinal specialist.
That's really important to know.
There are new treatments now, in addition to surgeries and things like that. There are now laser treatments that are being used to stabilize retinal problems.
That's really interesting. Kiana wants to know, will the MRI then become the recommended test for babies born with a port Rhine around the eye?
That is correct, yes. And depending on the age of the child, if it's on the younger side, sometimes you can even give the contrast and still feed and wrap and put them in, and they go to sleep because they're so little. The little bit older ones may not tolerate getting the contrast given, but even an MRI without the contrast can give us subtle signs that tell us, all right, things look fine, we can wait, or no, there's some subtle changes that suggest that there's brain involvement there, and we need to go ahead and do a sedated, contrast-enhanced MRI to, try to make the diagnosis. We're not putting every child who has a facial port wine birthmark in this area on a seizure medicine, low-dose aspirin. But if we make the diagnosis of significant brain involvement, then we do, to try to prevent the stroke injury to the brain and the impairments in blood flow that come with the really long seizures that the little babies can have. Untreated, 90% of babies with a birthmark in this area who do have brain involvement, 90% will have early seizures. And if we treat them, that goes down to about 50%.
That's significant.
It's significant, and the outcome at 2 years is better. We're starting to study later outcome, and so far, very early indication is that improvement with pre-symptomatic treatment is sustained. And
you did this study with Boston Children's,
correct,
right?
Correct.
Yeah.
So we
and it
put
was
our
a good size.
We put our data together. So it was 92 babies.
Yeah, that's a good number.
32 who had been pre-symptomatically treated, 60 who had not been.
So I'm really excited about this. So we have a number of questions. Draw Ann. Now, I'm going to correct her on this one, but she says, we are grateful for everything my daughter has done, laser, and we've prevented to make glaucoma at her eye because we started laser when she was 1 month. Well,
yeah, so we don't, there's no actual evidence at this point in time that I'm aware of that lasering around the eye prevents glaucoma. There's not really any evidence that it makes it worse either. There is evidence that early laser improves outcome for the skin. And so, that's something that we could take a look at in the future. But right now, the early laser is started so that the long-term consequences of having the birthmark and everything that can happen later in life is prevented or reduced.
Yes. Again, I'm so excited about this, right? Like, it was something we talked about a couple years ago, of the 3 facets: the birthmark, the glaucoma, and the seizure, and ways to just, and what it really all moves back to is, like Dr. G, early with the laser, with you, early with the eye, early with the imaging studies to rule it out or to get them on the medicine to stop this. For me, this has been the most significant improvement, because we're going to prevent, or that's the hope, seizures where there could possibly be irreversible damage too.
Well, right. The brain is very hard still to restore back to normal after it's been very injured, and so we can make things better, but it's better still. And all of child neurology really is gradually moving in the direction that it's better to prevent the injury to the brain whenever possible than to try to heal it once that injury has happened. And it's not always possible to prevent the significant brain injury, but in this situation, when the children are born with a birthmark that tells you before there's a problem that there's a risk, so that diagnosis can hopefully be made, and there's still some challenges with that, but it's definitely moving in the right direction, and start on treatment to prevent the seizures, prevent the strokes, that we then are looking at preventing brain injury, because we know that the children in the first few years of life, they're at highest risk for the very severe repetitive seizures, the brain injury, the stroke-like episodes. So if we can get them to 4, 5, 6 years of age, things tend to stabilize. And so that's the idea, is to get them past these first few years of life where there's a really high risk of bad seizures, high risk of brain injury. We want to prevent that.
And this is where all of our moms have to really push their primary cares.
Yes, that's right.
Because we're still seeing such a significant percent that won't refer them with the port wine, or they think it's a hemangioma and it'll go away, and then the families end up having seizures or vision problems, and they're like, why didn't you refer us?
Yeah, that's right. And here's the thing. I mean, I had, being a clinician myself and having taken care of other children with other rare diseases in the past, it's challenging for any pediatrician or nurse practitioner or even dermatologist or child neurologist or ophthalmologist to be aware of every rare disease and how best to take care of them. So it's really important. Yes, we are working on getting the word out to, going to meetings and talking to our colleagues and writing. And we have a webinar that we're giving in May for providers. But it's so important for parents to realize that their role in sort of, working with the VBF or people who know, and then taking information to your local providers that shows like what is needed is really very important, because they can't possibly know how to take care of every rare disease. There are thousands of them.
Yeah, and I think we need to work on, and I'll work on this with you, just a little card that we can make up that they can take for early screening and early this. Like, we'll put it on our website, something that they can take, because like you said, these moms that are in the delivery room and finding out their baby has a port wine need to know that they need to get them in early, and they're not going to get that unless we lobby our army of global ambassadors.
And that, that was hit home to me recently, because we published this study in January. I just went to like the national, international meeting of child neurologists, and almost none of my colleagues were aware of the study or knew, or, so I spent the whole meeting just sort of going around and telling everybody that, look, there should be a different approach here, and, we will be working on getting guidelines and, information out. I have connected with the AAP, and maybe you can help me with that.
Yeah, because and Dr. Cohen, because he's still on the liaison. But I'm thinking like what we did with the port wine stain guidelines. Maybe we need to have a little fact thing on Sturge-Weber syndrome guidelines for new parents, because we did just launch our new parent package, but we've got to really put that in there on our page to get in early for the eye exam and the seizure and the laser. Those three things should be done within the first month, scheduled at least. Let's get some of these questions answered. My 7-month-old nephew, Megan, says, just began aspirin to prevent seizures. When can he begin anti-seizure medication? He's 7 months.
He can begin it now, and usually, what we use is either levetiracetam, usually levetiracetam, also called Keppra, or oxcarbazepine, also called trileptal. And so, you can bring those options to your provider, and also you can go, if you put into if you Google Sturge-Weber retrospective pre-symptomatic treatment, you'll pull up our paper, at least an abstract for it or the summary for it, and you can share that with
We have
them.
it on our website too.
Oh, perfect. So just go to the website
and click on Sturge-Weber syndrome, and under the booklet, the facts that we did, the FAQ, new parent, then you'll see the links to all the papers.
Right. It's a really important, for new parents with new babies who you're not sure, it's a really important paper to share with your local providers.
Alice just wanted to add another note to you. She was the one whose son had a glaucoma surgery.
Yeah.
That he failed the eye drops. Like, he just couldn't keep the pressure under.
That happens sometimes, and so some babies, the important thing is to get in early, because if the high pressure is allowed to continue, the eye will actually enlarge, and then after that, the vision, the optic nerve becomes very damaged and can just reduce vision permanently. But drops sometimes work, and if one doesn't work, then they'll do 2 or even 3. If drops are not working, the pressure is really high and it's not coming down, some babies need surgery done to relieve that increased pressure in the eye, so that the eye doesn't continue to enlarge or threaten vision.
Yeah, and we're going to be, one of my board members, Benita, is bringing her pediatric glaucoma ophthalmologist
Great.
to be more involved with VBF and start
Super.
coming to our clinics to
Great.
discuss about some pre-screening and some tips that he can give the parents for what to look for.
Excellent.
Which is something I've been trying to get.
Right.
Okay, so she said, Alice said we made 5 operations in Swiss because we had complications. Also, I don't know what that is.
Cataract, maybe?
Oh, then maybe it was cataract. For the moment, the pressure is low with drops, Timagel. Can we make an appointment online to talk to you? Which they can, right?
They can, so you can make an appointment to talk with me, and if there are questions that I can't answer, I can share them with our pediatric glaucoma specialist. As far as I know, she doesn't do online visits, but I have them as a resource to sort of consult and then get back to families with their thoughts. I have to say that a lot of times, understandably, they feel very dependent on, having their own exams. But I'm happy to try to help. And yes, we do telehealth visits internationally, and I'm able to do telehealth when the patient is located in Nebraska, Tennessee, and I think it's Minnesota. Those 3 states. If they're physically located in one of those states, I can do telehealth from there as well.
It's awesome. And she will be at our clinic in March in London.
Yeah.
So all of you who've signed up for London, which is the largest registration we've had in our history.
Wow.
We're now up to 100.
Very, very excited.
And then you'll be at our clinic in Italy in June.
Yes.
And then October in New York.
Correct.
So you have, and there's a possibility.
I'm still, I would love to go Romania.
Right, but we'll see.
Yeah.
But those 3 are chances that you have to see Dr. Comi in person at our super clinics for free for a consult. You can find information for that on our website. We've launched London. We will be launching soon Italy for registration for June. And we won't be launching until March, the Romania one and the October. She's also at the October clinic in New York City. So there's 4 chances in 1 year to see her in person. She just wanted to know, do you know a good specialist of glaucoma? Well, I don't know that you know of one in Europe. I don't know of any in all of Europe.
I don't.
And I don't know, Advilite laser proper to port wine. I've never heard of it, and I'm a member of the Laser Society, and I pretty much know the name at least of all the lasers. I don't know if you've heard of that Advilite.
No.
I'll do a little research on it if you want to private message me at vbfpresident@gmail.com. I'll take a look. I'll ask my laser experts, because sometimes there's these cosmetic lasers that are out, and doctors will be like, oh yeah, I can treat spider veins. I could probably treat your birthmark. And they're really not recommended for vascular birthmarks. So it's good to check. Aaron wants to know, my 2-week-old newborn, great, you got a new one, has port wine on the right side of her face, number 11 in the chart I saw on your page. So I had them all number 2. So it's the zone. We have an initial appointment with a neurologist here next week. I don't know where here is. What questions should we ask? I have so many, but what is most important? So far, our doctors have been saying, don't worry, no rush for MRI. It's probably fine, but I want the earliest and best treatment possible for our son in terms of laser and preventative meds for seizures, which is bravo to you, Aaron, and congratulations on your 2-week-old newborn baby boy.
Absolutely, and you could start with downloading that paper. on pre-symptomatic treatment, and that's on the VBF website, and sharing that with your pediatrician and with your child neurologist. I don't know where you are, if it's possible. I have some families that come for a visit to like ask all their questions. A first time visit is about 90 minutes, and so we sit down and talk about everything. You're going to want to ask, like, what do seizures look like? What do you do if there's a problem?
Do they need a monitor?
Yeah, do they need a monitor? And you're going to want to,
and if they're going to school, how do you prepare the school?
Share the papers to advocate for not waiting to get the early imaging done, because you have this window of time where you don't have to sedate the baby. Okay, when they come and see me at 3 or 4 months of age, if everything looks great, exam, history, EEG is another tool, completely safe, that can be used to like look at the brain activity. And so if they're older, then and everything checks out good, we'll just follow them clinically with exam, history, EEG, and then do the imaging after a year of age. But they're coming at 2 weeks of age, then there's this opportunity to go ahead and not just do the history, exam, and EEG, but also get a non-sedated MRI of the brain, and use all of that to try to determine if the child is in a higher risk, or actually make the diagnosis, or see if they're in a higher risk category even than before, or if everything looks just great, in a lower risk. And I do think that makes a difference. It should make a difference in how closely the child is followed, how many times they're seen in the first 6 to 12 months. And also, just in terms of how the families are sort of addressing or going at that first year of life, and whether they decide to use monitoring or not use monitoring, different decisions like that. Also, after 3 months of age, we look at in the little babies, what should they be doing if a seizure starts? What does it look like, and what they should be doing? But also, if they're a little bit older and able to get an acute seizure medicine, how does that work?
Right.
So,
there's a lot.
There's a lot.
Yeah. I have a question. So, if we have a 1 or 2 week old and they have an EEG, is it going to be the same as if they have an MRI?
No.
So the MRI will pick up more subtle.
No. So an MRI is it's no radiation. No, if it's non-sedated, there's no sedation. The best study is with contrast to help us see the abnormal blood vessels, if the baby's young enough to tolerate that. But it gives us a picture of the brain, and it shows certain functions, like you can look at perfusion of the brain, blood flow to the brain in a variety of different ways, but it's actual pictures of that. EEG is like an EKG, where they look at heart activity with those squiggly lines on the screen, only instead of heart activity, it's electrical activity in the brain, and it's little squiggly lines on the screen. And so the two are complementary to each other, because EEG is the standard tool for the diagnosis of seizure or pre-seizure abnormal brain activity. The MRI doesn't look at that at all.
Will the EEG pick it up if it happened a month before?
If a seizure happened a month before, what we'll often see in between seizures is slowing, so the squiggly lines are slower, or lower, so instead of being taller, they'll be sort of, we call it low amplitude, or there'll be abnormal spikes or sharps in the squiggly lines. And those are indicators of brain that is not functioning optimally, and that's prone to seizure activity. And we know now, since the study that we did between our two sites, Boston and Kennedy Krieger, that children who are destined to begin having seizures in the next, days to weeks to a month or two, are much more likely to have those abnormalities on EEG. So we put all of that data together, the history, the exam, close, good neurologic exam, the EEG, and the MRI if we can get it, at a young age, particularly if we can get it without sedation to make the diagnosis.
With or without contrast?
I mean, if we're getting them at 2 weeks old, you can oftentimes, depends on the baby, but oftentimes put the IV in, which hurts, but you feed them and then push the contrast in, and they fall asleep, wrap them, put them in the scanner, and you're fine. When they get a little bit older, closer to 2 months of age, you go to put the IV in to give the contrast, and they don't go to sleep.
Yeah,
they get upset and don't sort of fall
Yeah.
off to sleep as easily. And so, now on the other hand, if history, exam, or EEG suggests a problem is there, then one should definitely just go ahead and do the contrast
MRI.
enhanced
Okay.
MRI and even sedated if that's what's needed.
Yeah, because at the point where you're starting to see some suspicious things,
Right.
then you got to really get a good handle on it.
That's right. Because oftentimes we'll see these suspicious changes, but the brain itself still looks okay. It's not atrophied. It's not calcified, and that's where we want to begin intervening. Where we are able to see the changes that tell us that they have Sturge-Weber syndrome brain involvement, but before the brain area has shrunk, before it's calcified, because once those things happen in the brain, it's hard to reverse that.
Right, that's important. We got a lot of questions. So Megan says, my son is 6 months with a port wine on his right eye and forehead, though it's pretty small. He's having laser treatments. Is there a correlation to the size of the port wine and Sturge-Weber?
There is, but so a large birthmark that's covering much of one side of the face has a higher risk than a small one, or one covering both sides of the face has an even greater risk, close to 50%. But I have seen children who've had just very small birthmark on the forehead and have had brain involvement, or a very small birthmark, just this area, upper eyelid, to forehead or to temple, and have had brain involvement. So if there's any port wine birthmark, capillary malformation in any of that high-risk area, there is a risk, an elevated risk. And generally that risk for all birthmarks is about 20%, but it can range 20-25%, but it can range from more like 10% to 50%, depending on the size and the extent of the birthmark.
So we have a lot of questions to get in for the next 20 minutes. This is a good one from Jennifer Lynn. Why would my 24-year-old son, who's been seizure-free, all of a sudden start having seizures?
There are multiple possible reasons. It could be that he's not taking care of himself as well, so not getting enough sleep, not eating and drinking water well, under a lot of stress and not really taking care of himself. It's also possible that, seizure medicines don't mix very well with like street drugs or alcohol. Not a good idea. He could be smoking. That's not a good idea.
Vaping,
smoking, any of that. Not a good idea. It cuts down oxygen in the blood, and with the abnormal blood vessels in the brain, you don't want to do that.
Except people are using smoking medical marijuana for their seizures.
Yeah, well, I can't really. I know it's happening, but I don't advocate for that, so
Yeah.
I can't really comment. So.
Right, we're hearing it, but we don't
Yes.
have any
Yes.
factual info.
Right.
And Megan's saying she can't get an appointment to see a neurologist for 8 months. So you could do an online consult.
Well, so I am able to do. Please reach out. We can certainly find out. Again, I'm able to do online consults if from certain states, if the patient is physically located. They don't have to live in that state, but physically located in that state at the time of the visit. For many, but not all countries, and it really is not on me, it's the international telehealth committee at the Kennedy. They know all the laws in the different countries and all of that. And then, of course, for those for whom that's, not a possibility, I will do things like look at scans and just say, yes, this looks like there's brain involvement, or no, there's not, if the imaging is sent to us. But otherwise, for like a full appointment, we need to either see you in person or at VBF or telehealth in sort of, in the ways that I'm legally able to do that.
So make sure Gina or whoever's on for VBF to post Dr. Comi's email. We have a question from Sabrina. Dr. Linda mentioned that my son might have Sturge-Weber without having a port wine stain on his face. He has had a few seizures, has hydroencephalus with a high T2 and fair skinned. He does have staining on his body.
Okay.
And seizure and hydroencephalus.
So the weight and the child is how old?
He's months old.
Okay.
So I think he's like 6 months.
Right. I mean, so an MRI with and without contrast, and there are certain sequences within the MRI that are helpful for getting the best possible study. Would be how we would know whether because I have seen, I don't know, a couple of patients over the years who had even a birthmark on the face and had seizures, but there's no Sturge-Weber syndrome brain involvement on proper imaging after a year of age, and they just happen to have the birthmark here and epilepsy for some other reason. So, I mean, that can definitely...
Like a double hit?
Well, I mean, two unrelated, right? It's probably that the way we understand it is that they have, birthmarks are not that uncommon, and there are lots of other causes of epilepsy, but that's unusual, and certainly
the hydroencephalus, we've seen that with some Sturge.
Yeah, I mean,
extensive staining.
If you have imaging that you would, like me to look at, you can reach out, and one of my research assistants, coordinators will, work with you to get the imaging transferred in a HIPAA compliant, private way, and I can take a look. Just please be careful to ensure that any and all imaging of the brain that you've had done, that I get a copy of everything that's been done. All right, so I'm not looking at partial information
or a clinical photo and no imaging.
Yeah, right.
Okay, yeah, that's good. So we have a couple more questions. Mike wants to know, does GNAQ548 mutation still play a role after birth or when a pediatric patient grows up? How about the role of PIC pathway or ERK pathway after birth, since this is a loss of function mutation? Any rationale a gene therapy could work here? That's
okay.
So
a
couple things.
The most common mutation for Sturge-Weber syndrome and port-wine birthmarks on this part of the face is an R183Q mutation in GNAQ. And theoretically, gene therapy development of that is possible. We and others are working on it. It's not yet, sort of available for any drug trials or anything like that. In adults or older patients, so in pre-symptomatically diagnosed patients, something like that would ideally normalize the function of that protein and prevent problems. But even in older patients, the expression of that protein is less as a person gets older, right? So and the risk of seizures is less. The impairments in the blood flow tend to not get normal, but at least not continue to go down. What the hope would be for like gene therapy or other targeted treatment for an older patient or an adult would be to continue to keep normal the activity of that abnormal protein in cells affected. So because we do have concerns about what can happen later in life. So and I do see adults, and our experience is growing, but still most of the adults that I've followed for a long time are in their 20s, 30s, early 40s. So there's a lot we don't know about the problems that can happen in the 40s, 50s, and 60s in these patients, but it does look like there are issues that can develop in that age. So we would hope to stabilize with gene or targeted therapy the function of that protein, even in adults and in older patients. It is actually a gain of function mutation, or at least that's how it's understood to be.
It's interesting.
But there's still a lot of work to be done because it's not it doesn't grow like a tumor. It does evolve over time and change over time. And there's a lot of work that we're doing in the lab, and other groups around the world are doing as well. And we talk to each other and try to keep moving that forward in terms of understanding how the mutation affects the function of the blood vessel,
and
cause
other
problems.
parts too.
And other cells.
We just participated in a graduate study on hearing loss in Sturge Weber, and her preliminary findings are 75% of the patients that had a Port Weinstein on that affected ear had hearing loss. So we've been trying to quantify that data, and I think this is beneficial.
Yeah, very, very important. One thing I have done for years, or have recommended for patients, is to be aggressive with ear tubes if they're having repeated ear infections, because
That's important.
Yeah, that may be part of it. Probably isn't all of it, but that may be part of it.
So we're down to 12 minutes. It's been crazy, like busy, which we always expect. Dinku has a question. She said, I'm the mom of a 2-year-old dark-skinned baby, and the last time she was treated, it was taking too much time to heal. The doctor burned her skin, even though I told him to use lower settings. He said it won't help if it is a low setting or may take too much time. The higher the setting, the more will be effective outcome, ? Well, I know I can say that anyone with pigment that's so skin goes on the Fitzpatrick scales, 1 to 6, 1 being the lightest like us, and then 6 being dark. And I only trust a handful of doctors in the world, because you have to understand the laser seeks for hemoglobin, and if there's melanin in between that, meaning brown skin is dense melanin, it chugs through it and has a less effective outcome for the stain, but then it can have some necrosis of the skin that has melanin, so it can hypopigment, hyperpigment, ulcer, scar, or burn, which is why I tell everybody to go see one of the top 5 laser kings like Geronimus, Nelson, Goldberg, Anderson, Duarte, Garner. They know how to modify the laser for skin type. You can't just go into someone. And by the way, when we come to London, that's one of the things Dr. G is going to be instructing, is treating different skin types, which is very important. So you can message me if you want, if you need to speak to somebody else. Lacey Burke, hi Dr. Comi, we saw you in New York after Dr. Coletti discovered my son's AVM. I remember that, Lacey, because I was suspicious of it. And I told Dr. Coletti I have 5 patients that I need you to ultrasound that might have an underlying AVM. And it says no brain involvement, but Dr. Coletti said the stain on the brain is on the nose and the forehead. Well, I can tell you, just because the capillary involvement is there, and even if the arterial is below it, it doesn't mean it's on the brain. Intracranial AVMs do not correlate to extracranial AVMs typically. And if that was even a possibility, there would have been more conversation on that. I think what Dr. Cletty was saying was, on imaging, it was behind his nose, and that can be in the back part of going to the back of the brain. So he was just saying, I don't know how far back it goes.
Right. And again, if there's a question there's been updated imaging of the brain or any question, please, feel free to reach out and we can take a look. But that's absolutely right. I mean, there's sort of intracranial, which is under the skull, within the skull, and then extracranial, which is outside of the skull. And the vascular systems can be, one can be affected and not the other. So
yeah, this one is so important from Kay Callan. What are your thoughts on hemispherectomy surgery if my daughter has all of the changes to her brain are on the right side? She's 19 months, has been selected as a candidate for surgery in 6 months. We're naturally concerned about such a procedure. Do you think if we went ahead, she would meet her milestones?
There isn't any way for anyone to promise that, and that the whole sort of pre-surgical decision making and questions about that is like a whole complicated discussion that needs to be for each child, really. But a few main things are that the main indication for hemispherectomy or hemispherotomy, which is similar but not as invasive, is just basically disconnecting the affected area of brain from the rest of the brain and from the body, is uncontrolled seizures. All right. So if the child is not having uncontrolled seizures, then you have to look very seriously at the risk benefit of doing the surgery, which can have, if it goes smoothly and very well, this is a good age to contemplate it if the child is having refractory seizures. But if the seizures have stopped and you're not having any seizures for the last 6 months or more, then you need to see how the next 6 months go before you commit to that, because there are, it's obviously significant surgery. You want to be in the hands of someone who's done it a lot, and there can be complications that, the outcome may not be. It's safer than it used to be, though, and I am recommending it more than I used to, because the surgery, instead of removing that entire hemisphere, which is clearly a lot, it's more like disconnecting, so the intervention is getting safer than it was. But if there are questions about that I can help with on a sort of either telehealth basis, or we do have a pre-surgical clinic, meaning for Sturge-Weber syndrome, and myself and a pediatric epileptologist who works hand in hand with the surgical group at Hopkins. And so once a month, we'll see patients who are thinking about or may be candidates for surgery, and just the both of us, myself from a Sturge-Weber syndrome standpoint, Dr. Marashley from an epilepsy surgery standpoint, sort of talk through and give our opinion about, whether that's, the best option, and try to answer questions. And then there are obviously a few options around the country for good places to go to who are experienced in the surgery.
It's amazing. Coming down to the wire, another good question. We're on clobazam.
Clobazam, yes.
And topiramate and aspirin. This is a treatment that initially gave us at the first seizure at 6 months. Since then, we had one seizure at 2 years on enterocolitis and enterocolitis and fever moments.
Sounds like
Maybe
some kind of illness or
like
inflammation.
Maybe an encephalitis.
I don't know. Entero is usually GI.
Right. Oh, enterocolitis. So maybe it was colon. And another at 4 after a fall in the park. Since then, seizure free with this treatment. I see that levetiracetam is the base treatment. Do we have to change it? Can it be changed?
So, I intermittently see patients who are started on other combinations, and if they're tolerating it well, developing well, cognitively doing well with like language development in school, and not having seizures, I don't necessarily change it. If they're having notable side effects, or for example, with Topamax, one of the most common concerns, and it is language development, or just slower expressive language, and that Topamax in adults can interfere with word finding and cause expressive language issues. So we will sometimes try to either, if they've been seizure free for a long time, get them off a medicine that's causing side effects and just be on aspirin and one other seizure medicine. But if the child is doing well on those medicines, not having seizures, not having apparent side effects, then I'm not going to change them. You can keep things like levetiracetam in the back of your mind if seizures go out of control, and switch them. But
okay, well, we got to get a couple more in. So can you just give a description of the criteria for when Sturge-Weber has no brain involvement?
Okay. Yeah. So we talked a lot about sort of very early in the first few months trying to make diagnosis of brain involvement as often as we can. For the patients who get through that and they still appear to be seizure free, I recommend, and most parents, not all, but most parents will obtain an MRI with and without contrast and sequences like SWI, ADC diffusion weighted imaging, perfusion imaging. These are all MRI sequences after a year of age. And if they get appropriate imaging done after a year of age and it doesn't show any Sturge-Weber syndrome brain involvement, then they are excluded. And I don't continue to follow them. I have never, now maybe they're out there, but I have never seen a patient who I was certain their brain imaging looked great, no questions or concerns, come back years later because they started having seizures and now they have brain involvement on imaging. And I've obviously been doing this for a long time. So
thank God.
Yeah.
Quick one again. So Alexandra says, our 5-year-old son has Sturge-Weber. He's been treated with carbamazepine.
Yeah, carbamazepine.
And Timonil and aspirin.
Mm-hmm.
He had the first seizure at 9 months and then at 5 years and 7 months. Is this a good treatment plan then? So it's like 4 years in between.
And he's now 5 years old.
And 7 months.
Right. And carbamazepine. So, it depends on how long the seizure was, right? So if it was a 30-second or 1-minute seizure, it ended on its own, and he was fine afterwards with no weakness or problems, then what you may want to do is it's possible that he outgrew the medication that he's on, and you just need to go up on the dose and maintain the same either milligram per kilogram per day dose or same blood levels as the child gets bigger. Because what can happen, and one of the reasons, not the only reason, but one of the reasons why a child who was seizure free for a prolonged period of time then has seizure again is that they outgrew their dose. And you can't prevent all illnesses, but a child starts going to school and they've outgrown their dose, they can get sick and have a seizure. If going up on the dose, or if that medicine is maxed, then we end up, and the child's still having seizures, we end up switching and to any of a few different seizure medications. Levetiracetam and oxcarbazepine are two of the commonest, but we also not uncommonly use clobazam. Epidiolex is another common one that we've shown to be particularly effective in patients with medically refractory seizures, or just for cognitive status and mood.
Okay, well, I don't want to lose these two questions,
Yep.
but we do have to go. But no, Ashley Lay, we did not see your question. If you can quickly get it in. George says, my son is 5.5. He had his first seizure at age 8 months. When he had 5 seizures in one day. As a matter of urgency, he underwent a CT and later an MRI. Then I found out that he had Sturge-Weber. Since then, he's on treatment with Timonil and carbamazepine.
Carbamazepine.
Yeah, recently at age 5.
Timonil, is that? I'm not sure what that is.
Yeah, I think it was a
Phenobarbital.
topical. Yeah, I don't know why I thought it was a topical. And what lasted a little absence, lack of attention. Before that, he was very tired, spent 4 hours drawing. Can you tell me if this is a cause of the crisis, that he spent too much time watching the cartoons? We also want to know if you know a professional specialist for choroidal hemangioma. We were told at age 7 to be giving him radiotherapy for this choroidal hemangioma.
So, I mean, there are not very many pediatric glaucoma and retinal specialists. I do work with a couple who are at Johns Hopkins and see patients out of offices in Baltimore or the DC area. And depending on where you are, they may know someone. So, if you reach out and ask, I can ask them, but just, you may need to travel. You would want to, they're generally found associated with like the most, the highest profile or the main academic centers in that state or that country or that area. But not every state and not every country has, have these sort of super specialists, really.
Well, anyways, it's been crazy busy like you always are, and thank you once again. I hope that your family has a healthy, happy, prosperous remaining of the year, and we know Christmas is coming. We will be seeing you in March in London and again in June in Italy, and who knows where else in between. But thank you very much for your time. In the comments, you can see the questions. Go back and play this and hear her answers. Also, Gina will be putting her email and my email in here for further follow-up, and we will be coming back and doing another Sturge-Weber syndrome Facebook Live next year. So thank you all and happy holidays, and thank you again for your expertise.
Take care.